From the News Channel 5 Network, this is Medical Mondays.
Good evening, everyone, and welcome to Medical Monday. I'm Carrie Sharp. Thanks so much for choosing to be with us tonight. Great topic on board tonight, and I'm hoping that we can answer a lot of your questions. We're talking about hip and knee replacement, and I know if you're contemplating that, you probably do have some questions, and you're probably living in pain, so you want to get out of pain. So if you have a question about hip or knee replacement, go ahead and give us a phone call. The number's right there on the screen. 615-737-PLUS is the number to call. We have producers in the back, and they'll get your phone calls lined up, and we will take just as many as we can on the air. Let me introduce you to the doctor we have here tonight. Dr. Rory Sandberg joins us. Thank you for coming in.
Thanks for having me.
You're a little bit new to town, have a practice. Tell people about your practice.
Sure. So the practice is called Pinnacle Surgical Orthopedics. Right now it's a two-man operation with myself and Dr. Kaminsky. I subspecialize in treating all of the disorders of the hip and knee, specifically in the patients as they age. So I kind of say over 40 or so tend to be a little more of the degenerative conditions of the hip and knee, and that's what I focus on treating. And then we also treat everything of if you've had a joint replacement and it's gone bad, it's not working, there's concerns, you still have pain, trying to be a one-stop shop for all things hip and knee.
What made you interested in hips and knees?
It's funny. The orthopedic surgery training is 5 years of training, and after my third year, I was kind of disillusioned with a lot of it. Honestly, I wasn't enjoying much of it. Hadn't done my joint replacement rotation, and started in on that, and was with a doctor named Dr. Miller, who's in Tucson, Arizona, where I trained, and he just did some really great work and helped a lot of people and had good results, and he took care of some of the things that not a lot of other people wanted to touch because they were afraid it was too risky or too hard, and it just really inspired me. It really rejuvenated my enthusiasm for orthopedic surgery in general.
It's a very cool story. I appreciate your honesty about that. Let's talk about when people find their way to your office and in need of help. What kind of condition are they in? What's your typical patient?
Typical patient, I mean, it really varies. There's some everywhere from a weekend warrior type that injured their knee or their hip, they thought they pulled their groin, and really when you start looking at it, it's early arthritis. And so we see everything from people that have had their first flare-up that really just need to be worked through non-operative steps appropriately, all the way up to we've had people that have had 2 or 3 joint replacements and they're still not working right, or there's a problem, and then they come in looking for help. So really it does run the whole spectrum of conditions that we end up seeing.
And hip replacement, at least, I think I read 120,000 per year in the U.S.
It's a lot.
Yeah, it seems like it.
It's a lot of replacements, and knees are becoming even more popular than the hip replacements in that regard. With the aging population, the baby boomers moving into retirement, we are finding that these surgeries are being performed at a ever-increasing rate.
Is it because the baby boomer population is becoming bigger and also we're more active?
That's a large part of it, and as our understanding of joint replacement has gotten better, we have better materials, we can perform them safely. I think in the younger, more active patient that maybe traditionally you would have tried to push off several years and say, well, you're too young for a knee replacement, but now, you know, it's fairly common to be doing joint replacements in somebody in their mid-50s.
Yeah. You brought some models here with me, and I love show and tell. Can you tell me what we're looking at here?
Sure. The first model that we have here is a representation of a total hip replacement. So this is the pelvis bone, this is the hip socket, this is the femur, the top part of the femur, and what this shows is really what the components of the hip replacement entail. So in a hip replacement, it's the joint that's gone bad, and so we actually will take a saw and we will cut the top part of the femur where the ball usually is, and that goes to the pathology department. And then with this see-through model, you can see that we actually put a stem down in through the center of the bone. It's hollow, almost like a piece of PVC pipe. And that has a very tight interference fit, we call it, and it has a surface that the bone will actually grow into. It's a roughened surface. And then we do the same thing on the socket side, where we actually will mill out the appropriate size hemisphere, put this cup in, and then we put a ceramic ball and a plastic liner. We put the hip back together, and instead of having painful bone rubbing on bone, now you have ceramic or sometimes metal rubbing against plastic.
I want to talk more as we go throughout this next hour about recovery and how quickly people are back on their feet and complications from this surgery. But needless to say, this is a big surgery. This is a big decision.
It is a big decision, and it's one that you have to make after you've heard all the risks and the benefits, and you make it most of the time at the consultation with your physician and your family. But that being said, these are not the same surgeries that were done 25 years ago. As a surgeon community, as really a hospital community and a healthcare community, we've gotten much better at administering this excellent treatment to where it's not quite the negative impact in your life that it had previously been, where you're spending days in the hospital and it's weeks and weeks and weeks and weeks of recovery. The process has become quite streamlined.
That's amazing. Has the prosthetic itself changed a lot over the last decade or two? I
mean, it has changed to some degree. Some of the materials that we've made for the bone to ingrow into these surfaces have gotten better with some advances like 3D printing and just the understanding of what makes a good fit for that bone to grow into. So that has definitely helped. Traditionally, the hip replacements for many, many years used cement to fix the pieces to the bone, and many people still use cement, and I'll use cement in certain situations, but more and more, as more data has come out and the advances in the technology, we're finding we can get away more with these, what they call press fit implants that grow into the bone.
That's very interesting.
Or rather, that the bone grows into.
Wow. Okay. I always say on Medical Mondays, we're going to take as many questions and calls as we can, because this show is about you. And I know I have, let's see, it looks like Lee is on the phone. Hi, Lee. Do you have a question for us tonight? Lee, you with us? They sure did. Okay. Well, Lee, hope you call back in if you get a chance. In the meantime, I'll just keep answering the questions or asking the questions. Dr. Sandberg will answer them for us. 615-737+ is the number to call. So we've talked about the hip a little bit. You also have a knee over there.
I do. So the knee replacement, similar principles. The knee's made up of 3 bones. The lower part of your thigh bone called the femur, the top part of the shin bone called the tibia, and then the kneecap also called the patella. And we think of the knee as having 3 different areas or compartments. So the inside part, what we call the medial, the outside part called the lateral, and then this front part of the patellofemoral joint. And so all of these need to be resurfaced as well. So in the knee, what's a little different is you really only take off about 1 centimeter of bone off the lower end of the thigh bone and the top part of the shin bone, and sometimes off the back of the kneecap. And then it's really a resurfacing. So instead of that painful bone, you put a piece of metal on both the tibia and the femur, a plastic shim almost in between the 2 of them, and then a plastic resurfacing on the back side of the patella. I will say that this is one that has more traditionally been done in North America. In Europe, this is not traditionally done, and there's more and more data that has some of us in North America questioning how often we actually need to resurface the back of the kneecap. So a lot of people are moving to a selective resurfacing of looking at it in surgery, taking into account age, size of the patient, how bad the bone looks, and maybe we're not resurfacing as many as we used to.
It's so interesting because really you are rebuilding that portion of the body and giving a patient a new knee or a new hip.
Well, in many ways that's true, and what's interesting that we tell people though is that as great as these advances are, this never replaces what you were born with. And so I think it's one of the biggest misconceptions we have is the term of, while it is a new knee in the sense that it's new to you, it does not feel like the same knee that you had when you were 20, for example.
Right.
In most cases, it's a replaced knee. It will feel a little different. The whole goal is to have it be a better knee that's less painful and functions at a better level than your previous one did.
That's a good point. I hadn't thought about that. Is it arthritis that brings a lot of people in?
A lot of times it is. There are some occasional conditions in the hip where in the native hip, the ball portion can actually have a disruption to its blood supply and the bone can die. You know, sometimes we see conditions called dysplasia that is kind of a malformed hip, but most of the time it's run-of-the-mill what we call wear and tear osteoarthritis, that over time the cartilage has just worn down, almost like the tread on the tires wearing down. And as that happens, it becomes painful as the bones start to rub against one another.
Okay. Very good deal. We've already learned a lot in this first portion of our hour here on Medical Monday. When we come back, your questions, hopefully, for Dr. Sandberg. I can see we have plenty of folks calling in on the line. Still a few lines open, though, so if you have a question, call us during the break and we'll get that set up. We're coming right back with more on Medical Monday.